Good afternoon, everyone. Welcome to our Bristol Health Partners Academic Health Science Centre conference. It's a great pleasure to welcome you all here. I can see there are already 87 participants and more to come. It's great that so many of you are interested and are able to make time in your busy diaries, particularly given the clinical pressures that we all find ourselves under. I think that this is a very exciting time for BHP, for Bristol Health Partners. If you remember, this time last year, we had just got designated as an academic health science centre, which coincided almost exactly with the outbreak of the pandemic. So it was rather muted and it rather got lost in the far more important things that everyone else was doing. So this is the first time we've really had an opportunity to all come together. And more importantly, we now have an opportunity over the last 18 months to reflect back on everything that we've been doing. Could I have the next slide, please? So in terms of the agenda for today, I'm not going to read all of that out to you, but essentially we've got some talks from Robert and Adwoa, then we have some HIT case studies, then a mental health focus, which Julian Walker from AWP will be chairing, and again some case studies, and then a PPI panel discussion, and then we'll move on to children and young people, and Anne and Joe will take us through, and then I'll do a final summary. Next slide, please. In terms of housekeeping, could everyone please mute with your videos off? The most important thing to note is that at appropriate points, if you'd like to ask questions for the speakers, and we won't be taking questions for the first keynote speaker by Robert Woolley, then please put them into the Q&A section, not the chat section. So if you hold your cursor over the bottom, you'll see that there are a number of different icons. There's participants, and then the one next to that is Q&A. That's where you post questions. I'll be keeping an eye on those. I'll read them out as appropriate. Obviously, in many cases, I'm sure we won't have time to go through all of the questions, and we'll make sure that we address them afterwards offline, particularly if you've left your email address. So thank you, everyone. Welcome again. It's great to see you all. We've now got over 100 participants, which is absolutely amazing. So I'm now going to move on to the next slide, please. And it gives me great pleasure to introduce Robert Woolley. Robert is chair of Bristol Health Partners, AHSC, and he is also chief executive of University Hospitals Bristol and Western NHS Foundation Trust. So without further ado, Robert, we're very glad you can give us the opening keynote speech. And Robert is going to reflect back on our outcomes over the last year and a half. So Robert, welcome, and over to you.
Thank you very much, David, and thank you everyone for being here. Can I welcome you all to the conference? It's great to see so many of you here. It will be a delight, won't it, when we're all able to get in the same room together, but in the meantime, we're making the best of Zoom. And I've been asked, as David says, to give you the overview of what Bristol Health Partners has been up to since that seminal moment, 1st of April 2020, when we were designated as an academic health science centre, one of only a handful in the country. So a huge plaudit, really, to the work that Bristol Health Partners does and the work that you do. If we go to the next slide, please, Simon. So the way we've built on that undoubted success of being designated an academic health science centre is to really think about how our health integration team model, which is the thing that sets Bristol Health Partners apart. And in many ways, I think we anticipated what the NHS long-term plan said about needing to grow collaboration and break down the barriers between various bits of the health and care system. We started to do that with the HIT model, and we are looking ahead again as the NHS moves into what is called an integrated care system world. So there will be a statutory integrated care system in Bristol, North Somerset and South Gloucestershire from next April, if the bill goes through Parliament as expected this autumn. And we've been looking at where research and innovation and professional education sit inside integrated care systems. And I have to say, there is not a great deal of national guidance about that. And as David and I know from our discussions with other systems, other teaching hospitals, this is something that each system is going to have to decide on its own. What we've done with Bristol Health Partners is to propose that we actually operate the Research and Innovation Steering Group for the BNSSG ICS. So effectively, Bristol Health Partners will be that steering group, and that really helps us bring together the formal NHS processes of planning and commissioning with the evidence base, the community liaison, the user perspective that we are gathering through the health integration teams. And building on that, it's phenomenal that we've had 8 HITs actually get special funding to develop projects in partnership with our community organizations and networks, particularly focusing on tackling health inequalities in the wake of the pandemic and trying to reduce pressure on the health and care system altogether. And that, of course, we can turn towards our key priorities that we've agreed as a partnership, which are around improving mental health of the population we serve, lessening those inequalities, and we'll hear a lot more about that this afternoon, and improving the health of children and young people and giving them the best start in life. If we go to the next slide, please, Simon. So we've also, excuse me, we've also had investment going into our HITs, which is part of our use of funding, but of course it creates value, and it creates value far in excess of the money that Bristol Health Partners is investing in the HITs itself. And though that money creates improvements, whether it be about pilots for green social prescribing or developing apps for users to access information, addressing barriers to perinatal mental health services. Those are particular improvements that funding helps to deliver. But equally, as I say, the NHS processes of planning and commissioning and what we're calling here the integrated care system programs, these work streams about transformation for the benefit of our population, 16 of them, at least 16, are aligned or properly connected to the HITs and the cross-cutting work that we're doing in the Academic Health Science Centre. Next slide, please. And this is what I say about unlocking value, that actually the benefit of what the HITs are doing is recognised through grants that are then flowing. £2 million nearly that you can see here that's come in to HITs in 2020-21 around Common Ambition Bristol and the Sexual Health Improvement Programme HIT, the SHIP HIT as we call it, the Green Social Prescribing that I've mentioned being taken forward by the Active Older People HIT, and modelling what happens if we eliminate hepatitis C amongst intravenous drug users in England, that the Drug and Alcohol HIT is doing. All of these things are of massive interest to research funders nationally, and NHS Charities Together, which is the national fundraising mechanism for bringing in support to help health and care through the pandemic. Actually, we've had over 300,000 come back into 8 of our HIT-led projects, building on work that supports the communities most affected by the pandemic, apps for self-managing care for patients with inflammatory rheumatic disease, or training people to become champions around trauma and understanding how trauma operates psychologically as much as physically, and being on the lookout for that. So really valuable use of that money. Next slide, please. None of this, I think, could be done and have the impact that it does have if we weren't actually engaging with and responsive to what our users and our public need from health and care. And that's what the partnership is about. That's what the health integration teams are about. And we've actually seen great strides around use of patient and public contributors into our work. So you can see 70 now, which is double what we had in the previous year. And projects like Common Ambition Bristol, which we'll hear more about later, actually are modelling the way that we bring community advocates in, and instead of giving people solutions that we've devised, we actually set about co-creating solutions that deliver what users need. We've got 7 PPI members who are actually embedded in the leadership teams of HITS, and we've got 2 members, Stephen Hill and Katie Wild, who've actually joined the AHSC board that I chair, and they're contributing there. They've also been joined on what I've already described, the Research and Innovation Steering Group, by 2 other members, Primrose, who's with us today, Primrose Granville, and Sumaya Boasida. They're active both in our HITS, and they're now on the strategic group as well. And of course, all of this is about making sure that the work we do is relevant to the people who need us. Next slide, please. We've trained, we've trained more than 150 ambassadors who are expert in adverse childhood experiences, and they are actually available to help promote what we call trauma-informed practice in workplaces, and actually understanding, as I've said already, the way that psychological trauma works and the way that people respond. Our SHIP HIT has been part of the Bristol Fast Track Cities initiative around reducing the stigma attached to HIV and reducing HIV infection itself. And one outcome of that has actually been getting £500,000 worth of grant money from the Health Foundation to set up that Common Ambition Bristol project, which I've described and which you'll hear more about. And we last year decided as an AHSC board that we needed to be very, very explicit about our commitment in the AHSC to increase equality and diversity, to promote inclusion in everything we do. And that it's not just words, I hasten to add. We've actually converted that into training sessions for our HIT leaders, actually looking at helping HITs change their working practices, both generally and specifically around, venues that are accessible to different communities and helping particular communities access services. And we've seen a real flourishing of HIT work last year around tackling inequalities in general. And of course, the pandemic, as in so many walks of life, has just exposed so much of the core inequality that exists in our society. So this is hugely important to us. Next slide, please. We are able, as you might imagine now with AHSC status, to actually reach outside of BNSSG entirely. One of the things we did was commission some work to develop resources for analysts, all the analytical colleagues inside BNSSG who do such great work for us locally. We created a resource for them that actually listed out all of the places they could go to access high quality data. That's been picked up by the Health Foundation, by the Association of Professional Healthcare Analysts, and they've taken it national. There is now a national resource website that makes all of that information available to researchers and analysts right across the country. We've developed a new app, which is now nationwide. It's supporting 1 in 5 UK adults, as you can see, around continence issues. It was put together by the Bladder and Bowel Confidence HIT and launched during World Continence Week in 2021. And that's been shortlisted for a Nursing Times Award, so clearly of huge value to users across the country. And I've already mentioned Stephen, who's on the AHSC board, bringing patient and public views into our board discussions, but he's actually been appointed to the NICE committee that's looking at stroke guidelines as a stroke survivor himself. And that work, of course, is playing back into work on the next slide, please, about how we respond to COVID and how we undertake the bigger transformations that we're looking to inside BNSSG. So great work around COVID, both to understand the impact, which will be of huge value when we come to trying to put services back for people insofar as anything can be the same again, trying to get routine services back for the people who need them. And some phenomenal work led by David Wynick himself to actually develop a simple scoring system, but nonetheless a way of predicting where the risks of COVID infection were going to land, who is going to be most vulnerable, and actually helping us prioritize then and influence the decisions that clinicians were making about care should patients become ill from COVID. And it's now in routine use across BNSSG as a decision-making tool. And the priorities that we've established are driven by our consideration of the pandemic as well. So as you'll be hearing this afternoon, mental health, the psychological impact, not just of COVID, but addressing mental health issues as a core part of many of the physical issues that the health service seeks to address. Health inequalities, as I've described, and of course, giving children and young people the best start in life as well. I will conclude then with the final slide, and great thanks to everyone who's organised the conference this afternoon and done great work to get us together. Huge thanks to all of the leaders of our health integration teams, but all of the members and participants in those HITs, because you are the essence of what BHP and the Academic Health Science Centre is about, and it's your work on which we rest. Huge thanks to the Bristol Health Partners core team for all of their hard work in the last 18 months. I know it's not been easy, and particularly to our co-chief operating officers, Lisa King and Ollie Watson, and special thanks, of course, to David Wynick as our Bristol Health Partners Director. Thanks, of course, to all of you, and thanks particularly to our community advocates, our patient and public representatives, many of whom are with us, I know, in the conference today, and some of whom are giving us their insights through the rest of this afternoon's programme. I'll stop there, and I look forward to the rest of the session.
Thank you very much indeed, Robert. That was a wonderful summary, and eclectic and short and sweet at the same time. You've managed, I think, most impressively to keep us to time as well. So we're going to move on now. We don't have time for questions, but there will be later, to Adwoa Webber, who is Head of Clinical Effectiveness at BNSSG CCG. So Adwoa, thank you very much indeed for joining us, and I'm delighted to hand over to you.
Thank you, and everybody. I'm just going to do a very short introduction, I think, to health inequalities before handing over to the other two speakers. And what I always do when I'm talking about this, you know, we've got 111 people on the call with probably 111 different levels of understanding and interpretation of what health inequalities actually is. So this is a definition that I like, and it's just to make sure we're all on the same page. So health inequalities are unjust and avoidable differences in people's health across the population and between specific population groups. And for me, the key words in there are unjust and avoidable. So just to bear that in mind. I'm not going to give you key stats about health inequalities in BNSSG, because what's key and to whom, and we've got lots of documents from the joint strategic needs assessments that the local authorities do to various analyses that tell us a range of things about inequalities. So what I thought would be more useful is to think about the fact that most, and if not all, of what we all do in terms of health and care and support and well-being, most or all of what we do has got the potential to make things worse for a group or groups of people, and or not close an existing gap. So I'm saying that because we've got some fantastic hits that are doing some very focused work with groups of our population. But actually, if we really think about it, all of the hits have an impact and the impact and the potential to close the gap. So it's just to sort of bear that in mind. And some of the examples I sort of think about is, you know, we make some quite big decisions about services and location of services. You know, the stroke hits an amazing example of some of the thinking around that and models of care. And then there are teeny tiny decisions that we make around commissioning and what we want from providers. And a practice nurse got in touch with me a couple of months ago to say that we've put in place something to do with exercise on referral, which is amazing. She's the practice's obesity lead. She filled in the form and realised that she couldn't submit the electronic form unless she put in her patient's mobile number and email address. And she said to me, a lot of our patients don't have a mobile number or email address, and I can't submit the form. And the response was from the people running the service, we have to do this because it's what the commissioners have asked for in terms of monitoring data, and there's no way around it. Why don't you ask the patient to use their friend's email address? So teeny tiny decision, why should this patient have to ask for an advocate just to get the support that they want to be able to lose weight, which is something that we think is a really valuable interaction. And then another example, there's a lot of chatter at the moment, and my research colleagues will probably slap me down because I haven't seen the research paper, etc. But there's a lot of talk at the moment about pulse oximetry and darker skin. So again, somebody came up with a great innovation that supports treatment and patient care, but there seems to be a bit of an issue about its accuracy when it comes to looking to measuring oxygen if it has to go through darker skin. So just all of this sort of range of things, and it doesn't say that we can't mitigate it, but if we don't think about it and think about the different aspects, then we could unintentionally widen the gap. So in terms of what we're doing in BNSSG, I would sort of describe it as a two-pronged approach. There's the approach that is actually, we've just got to get used to doing this across everything we do. So it's what I call the everyone and everything approach. And it's that encouragement about thinking about things from the beginning, thinking about what it's like for various groups of our population, etc., and thinking about what is termed intersectionality, which simply means, can we stop putting people in boxes and think they're one-dimensional? So I am Black, I'm also a woman, I also have a middle income, I live in a certain area of the patch, of the Bristol, North Somerset, South Gloucestershire patch. I'm unmarried, I don't have children, plants or animals, but all of those different things have a different, mean that I interact with the world in a certain way. So we can just look at race, or we can just look at ability or disability, and we can't, but just remember that people are made up of a number of different characteristics, experiences, etc. And those cumulatively quite often have an impact on their health experience and their health outcomes. So that, and so that's what I call the everyone and everything approach. But we are doing some more specific things. So as a system, and as Robert said, we are becoming formally an integrated care system next year. We've developed a population outcomes framework. And what that framework does is list the things that we want to achieve for our population, the improvements we want to make in their health, well-being and their environment. And within some of those, there are some targeted things around targeting particular groups where we know that there are particular gaps. So cardiovascular disease is one of those gaps. Another thing that we're doing sort of system-wide is public health have helped us put together a document that talks about where our inequalities are in terms of diseases. So thinking about life expectancy, healthy life expectancy, premature mortality, etc. And that's sort of condition focused. And that's helping us do some work to find out where in those pathways or those experiences the inequalities may be happening. So sort of at the end of these things, I always think there should be a sort of call to action, something to sort of that people can take away with them. And it's usually one thing, but I only managed to get it down to 3. So the first thing I think we all need to do, and by we all, I mean the public contributors, me, the chief execs, directors, people who are supporting people, we need to get really comfortable with being vulnerable. Okay, so this is a long ride. This is not something that's going to be fixed in the next year or 2. And we need to be really comfortable with being vulnerable because not all of us know everything. And we're really used to being experts in our field and comfortable with what we do professionally and in our social lives, etc. But actually, we need to open ourselves up and be a little bit vulnerable in admitting that we don't know or we don't understand, and actually being a bit vulnerable in terms of perhaps sharing some of yourself and your authentic self when we're talking about inequalities. So that's my first plea. My second plea is something that I'm really passionate about, and just be curious, be nosy, be curious. If you don't know, Google. If you don't know what it's like to be poor, Google something, the impact it has, then Google or find out or listen or read. But please, all of us, we really must maintain our curiosity. And then the third thing is something that sounds a bit trite, but helps me, which is I always try to think, what would this, and this could be a decision I make or a way of doing things. So what will this be like for someone who is not like me? And most people are not like me, but it does make me think, oh, hang on a second, I've got mobile data that I don't have to worry about. I speak English as a first language. How's that going to work? How is it going to work for someone who's not like me? And if we start to think about those 3 things, I think fundamentally we can really continue to build on all the good work that's going on in this patch, all the good work that the HITs are doing, all the great work that the NHS is going to do. So yeah, those are my sort of 3 little takeaways. Thank you.
Thank you very much indeed, Adwoa. If you're okay, I'm happy to leave your video on. I think we'll take a couple of questions if that's okay.
Yeah.
So while we're waiting for a few people to put some questions, I guess my comment would be is that as I've got older, I've become more and more clear that there is almost nothing I know anything about. And you know, I'm always minded of the old adage that, you know, if someone within my shoes, they probably do it a lot better, and if I was in their shoes, I'd almost certainly be doing it worse than they're managing. So I think trying to put yourself in someone else's lived experience is very difficult, exactly as you've said, depending on our own personal circumstances and characteristics. But if you can do that, or you can talk to someone who lives it day by day, then suddenly it opens up completely different windows. So I don't know if there's any questions in the Q&A. I can't see any at the moment. So given, one has just appeared. Thank you very much. And the question is from Francesco. Are the public contributors on each of the hits providing their perspectives and narratives to inform each of the ICPs and their insights, and how they will take this forward at a neighbourhood and at a place level to reduce health inequalities? It's a great question. I mean, my response as the director of Bristol Health Partners is yes, as much as we possibly can. Could we do more? Could we do it better? Yes, of course. I don't know if you've got some specific examples that you'd like to highlight, Adwoa.
No, nothing specific, except for it's a great question and a great point. And it's, I think all of us are on this, this exciting trip, you know, this trip that's got lots of opportunity to better use what we've been told and what we're being told by the public and by people who use services. So I think we've got some brilliant stuff in place that means that they sort of tell us things, but now the trick is to turn those into actions and to actually use them. So I think it's a brilliant question, and I think the public contributors in particular have got a real role in nagging us and holding us to account. We're not democratic local authority, and I think there's a real value in them pushing us as well.
Thank you, Adwoa. A couple of people asked about the report and where we can get information. We'll post the response afterwards as to where that can be taken forward. Can I repeat again and ask people to post their questions for the speakers in the Q&A section, not in the chat section? So given that we're on time, we'll move on now. And what we now have are 2 HIT case studies. So those are our health integration teams. So the first one is a pre-recorded video by Evelyn Schiller, who is a PPI representative in the stroke HIT. And then we'll move on afterwards to Aisha, who's a Bristol project coordinator in the Common Ambition, and she's going to do that in person around improving HIV. So over to you, Evelyn, and thank you very much for spending the time to record the video.
Hello, my name is Evelyn Schiller, and I live with sickle cell disorder. I have also suffered a stroke, and I am here to talk about stroke. I want to talk about the importance of preventing stroke in people with sickle cell. This is because there's a 24% chance that somebody living with sickle cell will get a stroke before they reach age 43. That's a very high percentage. But the great news is that we can prevent stroke. So I am advocating that we involve caregivers across the board. You know, children at school are with teachers. Teachers should know that a child living with sickle cell needs to hydrate throughout their class time. Adults in and out of school need to know that hydration is very important for people living with sickle cell, because it's a game changer. A stroke is a very debilitating thing. It can disable you. It can stop you from doing all the things you love. And so it's so important that we do all we can to help prevent stroke rather than wait for it to happen and then treat it. So I am hoping that this is going to go out to help us bring together a strategy that encompasses all of this, so that we could work together to prevent stroke in people living with sickle cell. Thank you very much for listening to me. Bye-bye.
Thank you, Evelyn. And I think it's worthwhile noting that Evelyn is working with others in the stroke HIT to actually really focus on getting the preventative message across, particularly for patients with sickle cell who have a very high prevalence of stroke, but more generally for the population. Stroke is largely preventable. The single commonest cause is hypertension, so diagnosing and treating hypertension early is something that almost every health care professional will be meeting people almost on a daily basis that could be helped and treated if only blood pressure monitoring were done earlier and more regularly. So thank you very much indeed, Evelyn. And we're now going to move on to Aisha. She'll talk for about 5 minutes with slides, and then again we'll take some questions afterwards. So Aisha, thank you so much for joining us. Over to you.
Hi everybody, so my name is Aisha. I'm the project coordinator for Common Ambition Bristol. I'm extremely happy to be here today, and thank you very much for giving me the platform to be able to talk about a project that is not just a project that I work on, it's a project very dear to my heart. So thank you very much. Next slide, please. So what is Common Ambition Bristol? Essentially, this is a 3-year community-powered project that is aimed at tackling HIV inequalities in Bristol, specifically within African and Caribbean heritage communities. We have 4 main aims. They are to increase HIV awareness, reduce HIV stigma, increase HIV testing, and reduce late diagnosis within those communities. Next slide, please. So we have various partners on our project, and I'm very proud to say that we wouldn't be able to do any of the work that we do without them, and they are all equally as important. I myself work for Brigstow, and we have a main community partner in African Voices Forum. But as you can see, there are many other aspects to this team, and all are equally as important. And I'm very proud to say that we have some great and fantastic partners on board. Next slide, please. So why Bristol? We know that Bristol has a higher prevalence of HIV than the rest of the UK average outside of London. We also know that we have an extremely high rate of late diagnosis. Bristol is essentially a true multicultural city, always has been. There is a high number of African and Caribbean heritage communities here with a strict sense of pride in everything that they do. Bristol is very much a forward-thinking city with people and communities who embrace change and lead the way against inequalities. You would have to have been living under a rock over the last 2 years to not see just how far Bristol will go to make sure that inequalities are both recognised and then things change. Bristol has extremely wonderful services when it comes to sexual health, great resources, fantastic commissioners, and lots of other agencies, much like our partners, who are committed to seeing real change within the city when it comes to inequalities. And we've realised that we have a need to create a sustained and informative project that creates change by our community, for our community. When I say our community, I am a woman of African descent, so I speak about my community very passionately, very openly. But we here, when we're talking about this project, are thinking specifically of African and Caribbean heritage communities. The needs of those communities sometimes mirror each other, but sometimes can be very different. So it's important that we as a project look at the needs of both of those communities and all of the intersectionalities that that brings with it. That is essentially why Common Ambition Bristol exists. Next slide, please. So I like to think of myself as a nice, wise Black woman, but it's always good to have some words of wisdom from another fantastic Black woman. So here we have Miss Maya. She is telling us that you can't really know where you're going until you know where you have been. This is words of wisdom that is not just from Miss Maya. It's a proverb in many cultures. It's something that we hear all the time, and something that I'm very proud to say Common Ambition Bristol has taken to heart. Next slide, please. In order to know where we had been and to know where we are going, we did a massive research project. For me, it was a huge deal, something that I've never been involved with previously, and I'm very proud that we did it. We looked at all published trials in high-income countries that have achieved an increase in testing in their areas or a decrease in stigma. This brought us back 386 papers. I told you this was a massive project. We managed to bring those papers down to 101 papers by thinking about specifically the interventions that dealt with Black communities and adults. Next slide, please. Those 101 papers were shared with our project delivery group. Our project delivery group is essentially the engine of everything we do at Common Ambition Bristol. It's made up of community members and professionals alike. It's an incredible group that I'm extremely proud to say have gone above and beyond for this project. The amount of work that they've done, the amount of knowledge that they brought to the table, and the amount of things that they've learned as they've been going along has been incredible to witness and incredible to be part of. So we took the 101 papers to them. They decided on 4 areas of work that they thought were specific for Bristol, that would be significant for Bristol, and 4 areas of work that they thought would enable us to achieve our 4 aims. So those areas of work, I call them the Fab 4, not the Beatles, but just the Fab 4. And they are multimedia. So with multimedia, we're talking about websites, podcasts, all of the usual things. Resources, because it was very important for us to have some resources, to create some resources that would be Common Ambition Bristol branded and help people within Bristol to know what Common Ambition Bristol is and to recognise it instantly in order for us to elevate the project. Then there were 2 very key areas of work, a barbershop or men's space and a women's space. Now, these 2 key areas of work were brought together because we recognise that over the last few years, there has been a rise in the need for safe spaces for our Black communities, and specifically for our men to be able to talk and for our women to be able to have safe spaces. Next slide, please. We decided on barbershops because we know that over the last few years, everybody has had things difficult with COVID, but I'm very sure that unless you've been sleeping under a rock for the last few years, it's impossible to ignore that Black communities have been thrust to the forefront when it comes to thinking about how we navigate certain spaces and people becoming aware of how we navigate those spaces. So it's been very important for us to make sure that we have a safe space where men can feel that they have a space to talk and to talk about their health, and a space for women to be able to feel supported, empowered and uplifted. So it was very key for us to have these spaces. Now this, very often people will ask us, well, if you're just dealing with a men's space and you're just dealing with a women's space, what about all of the people that feel that they sit in the intersectionalities between those 2 programmes? And this has been addressed as we move further on. I'll be giving a better explanation as to how this has been addressed, but it is being addressed by the project. Next slide, please. So we took our ideas, our Fab 4, our areas of work, we took them to a public consultation that involved citizens of Bristol, asking them what they thought of those ideas and to give us any feedback that they had. Our online consultation showed that multimedia and women's spaces were most popular, and that we feel is because it was predominantly women that were at the online consultation. Now, we had a face-to-face consultation at Eastern Community Centre, and I like to refer to this consultation as the unicorn of all consultations. The reason I call it that is because that consultation turned out to be predominantly young Black men talking about their sexual health, talking about what they wanted to know about sexual health, what they already knew, or the lack thereof when it comes to knowledge, but also talking about the things that they felt would work for them and for the community. So that was an incredible piece of public consultation that's helped us to inform how we move forward. Next slide, please. So where are we now? We've had the public consultation, we have the 4 areas of work that we had decided were important, but the public consultation gave us an idea of some of the smaller projects that we think could work specifically for the community and some of the projects that they felt that they needed. All of those projects come under the umbrella of our 4 major aims and under the umbrella of our Fab 4 areas of work that we wanted to work in. But by having those smaller projects, we feel that we're able to properly address the intersectionalities between the men's spaces and the women's spaces, but also to be able to bring in elements of talking to the youth and bringing in elements of dealing with other groups within our African and Caribbean heritage community that sometimes feel that not only are they left behind because they form part of the African and Caribbean heritage community, but also left behind because they sit in another box, as it were. And we're very keen to make sure that those boxes are broken and that people feel that they are at the very heart of everything that we do with Common Ambition Bristol. So those projects are at the stage of development now. They will be going live as soon as possible. It's a very exciting time for us, and I hope that everybody will be keeping an eye on the work that we're doing and supporting the project. Next slide, please. So this last slide is basically for me to say thank you for listening to the whistle-stop tour of Common Ambition Bristol so far. This is our social media page, so if you would like to follow us, get to know us, see the work that we're doing, if you have any questions, any queries, or you'd like to get involved, then please do reach out to us at Twitter at Bristol Common, Facebook at Common Ambition Bristol, and Instagram also at Common Ambition Bristol. We'd love to hear from you. Thank you very much.
Thank you very much indeed, Aisha. That was wonderful. And as you say, a whistle-stop tour, but at the same time, hugely informative. Again, while we're waiting for people to ask questions in the Q&A section, I guess my immediate question was, if you look at your Fab Four, you look at the young men as compared to the women, I'm guessing they were very different questions and different areas. Are you therefore planning, taking this forward, to have effectively gender and or age-specific webinars or information provision?
Yes, absolutely. So some of the smaller projects that have been brought to the forefront, specifically by the community, in fact, are projects that we know that we can tailor to different areas of the community. So it can be for older people, younger people, it can be for our LGBTQIA brothers and sisters. It can literally be stuff that we can roll around across the community so that we can make sure that nobody gets left behind. There will always be times when some of the things that we do feel specifically for certain people, but we will always try and mitigate that by making sure that we can roll out something else that works for the rest of the community.
That's fantastic. And is the information that you're providing going to be available online, so it's there as a point in time and as a record for others to access later?
Absolutely. That was one of the reasons we wanted the multimedia resource brought forward, was so that there was always somewhere that people could look at a website, know what we're doing, be sent along to other websites if necessary. But also what we really want with Common Ambition Bristol is for it to be something that leaves a legacy, for it to be something that genuinely changes Bristol for the better and informs the work that other people do as they move forward. Because as we've already said, you can't know where you're going unless you know where you've been, and essentially Common Ambition Bristol hopefully will be able to help us do that.
Excellent. So there's a couple of questions now in the Q&A, so I'll go through those. The first comes from Jo. She says, can you give us a sneak preview of any of one of the projects you're developing, and also any tips for good public consultation?
Yes, sneak preview. I think one of the ones that I'm really excited about is CAB Table Talks. It's essentially going to be something that we can take around to different venues, different places, different community groups, where we will be able to have open and honest roundtable discussions, reasonings, as we like to call it sometimes, where we will talk about sexual health, answer questions about sexual health, do a lot of myth busting, because stigma can only be broken down through myth busting. And it's something that we can take into barbershops, and we can take into salons, and we can take into women's groups and women's spaces. So that's really exciting. In terms of good community engagement, I think it's about, as has already been mentioned today, it's about thinking about how other people that aren't the same as you can access the information that you want them to access. And it's also about, when you're thinking about communities such as African and Caribbean heritage communities, you really need to get rid of the thinking that that community is hard to reach, because when that community feels that they are part of something and feels that the information or the work that's being brought forward is actually for them, then they are more than willing to come forward and be part of that. So always keep that in mind when you want to access these communities. It's not about originally putting up a barrier because you think they're hard to reach. Dismantle all of that, start from scratch, and just be open and honest with what you need and what you're willing to give them.
Thank you, Aisha. So one final question, which I think is a really important one, is there are very few sexual health clinics in Bristol, which gives a lack of choice. Is there anything being done to address this?
So we are looking at various ways of testing. We are looking at various ways of being able to bring testing to the masses within the communities that we're looking to address. It is something that we're hoping we will be able to do and we will be able to change, and essentially Common Ambition Bristol will be able to influence in Bristol, is the provision of specific clinic spaces for the specific communities that we're looking to tackle the inequalities within, because we know that there are a myriad of factors that mean that people can't access certain services. So the more that we can influence that, the better.
Excellent. Thank you, Aisha. It was a wonderful talk. Really appreciate your time and lovely slides. So we're now going to take a short break. So we've now got 8 minutes until 2 o'clock. So we'll do that. So if everyone wants to mute and just leave their screens off, there'll be a countdown on screen so you can tell when we're going to restart. And in the meanwhile, there's a Autumn Live poll, which we'd be very grateful if people could complete. So we'll start again at exactly 2 o'clock. Thank you. Welcome back, everyone. It's 2 o'clock. I hope you've all managed a comfort break. So I'm now going to hand over to Julian Walker, who's the Director of R&D for AWP, and to Primrose Granville, who's a public contributor. And they're going to chair the next half an hour, which is a session focused around mental health. So Julian, over to you.
Hi, that's great. Thank you very much, David. There are several of us in the next section, so I'm just hoping that I can see our cameras come up. So this is just a reminder to Carolyn and Darren and Primrose to put their cameras on. The next section is strongly about involvement in mental health, and I'm going to ask my colleagues on the session to introduce themselves as well. We will have a brief mention about involvement, which Primrose will do, and then we've got 3 videos that we will show consecutively. I'll tell you what they are just before they come up, and then the 4 of us are going to have a discussion about what we've seen. We'd be delighted to take questions in the Q&A and comments in the chat, and we will draw your comments and questions into the discussion that we have. So, could I ask Primrose for you to just say a few words about yourself, and then I'll come to Darren and Carolyn.
Hi everyone. My name is Primrose Granville, and I am a patient that lives with quite a few health issues. And when you go through several different health issues, some of them that occur simultaneously, you inadvertently end up with mental health issues as well, because it's actually quite stressful, and it leads you to go in a place where you don't really want to be. And that's led me to become involved in lots of things surrounding Bristol Health Partners. Thank you.
Thanks, Primrose. So, Carolyn, could you just briefly introduce yourself, please?
Hi, my name is Carolyn Trippick, and I'm one of the patient and public involvement leads for the Eating Disorder Health Integration Team, so also known as EdHIT. Having lived experience of anorexia and both inpatient and community treatment, I know firsthand how life-limiting and destructive the illness can be, as well as how hard the battle of recovery is. I got involved with EdHIT initially as somebody with lived experience to share my experiences and personal insight alongside other service user involvement with even a Wiltshire Mental Health Partnership. I later took on the PPI role with Bristol Health Partners to encourage others to have a voice, and through working collaboratively help improve eating disorder awareness, support and quality of care for those impacted by the illness. And I think the health integration teams really do make a difference. PPI is an integral part of that process.
Thank you, Carolyn. We're going to be hearing from the EdHIT shortly as well, aren't we? Darren, welcome. Good to see you here.
Hi, thank you everybody. My name's Darren. I'm a public contributor of the Public Health HIT team, and I've been a service user. I've been involved with PPI work, and recently involved with the team that did some work on co-production and mapping resources for co-produced research. So yeah, thank you.
Thanks very much, Darren. So Primrose, we were going to say a little bit about involvement, weren't we? And about what really meaningful involvement is.
Well, yeah, so I didn't give a lot away earlier because I knew I'd be talking about this. So I live with chronic kidney disease. I suffered from polycystic kidney disease, which is hereditary. I'm a transplant recipient. I also live with pain management, chronic pain, because I had an accident some time ago. And I get involved with quite a few things with Julian, which I get invited to. And I find that involvement has really opened up my understanding of what is available to me, how I can deal with things better. By getting involved, you learn so much, and you get so much support from being around other people that are living with any other kind of health issue. And it's actually quite uplifting. You know, lots of people say to me all the time, you go to all these health things, don't you get depressed? Actually, no, I actually feel a lot better for attending, because being around anyone that's living with a condition, it automatically lifts you to hear how they maneuver the situation, you know, how they get over things, how they get over difficulties, and you learn from them. And being somebody who lives with health issues, you develop this great big toolbox where everywhere you go, you pick up a new tool and you put it in that toolbox, and it helps you to actually live your life a lot better. So involvement in Bristol Health Partners has been incredibly positive for me, and I think it's brilliant. So that's my bit on involvement. Thank you.
And it does come up in a couple of the films later, doesn't it? But I mean, I think I would agree with you. I would say that it's my favourite bit of the work as well, and I think lots of clinicians would say the same thing.
Definitely.
You know, we're often reminded that it's not a late stage development. There are lots of different kinds of involvement, but the earlier you start, the better.
Absolutely. Totally agree with you, Julian.
So shall we get the films rolling? I'm just saying that for our colleagues behind the scene, who I hope are going to line them up. We've got 3 films that we're going to show you, and then the 4 of us will talk about what we've seen, and we'll be very pleased to take comments and questions that come through. You're going to see 3 films that will run consecutively. The first one is Ruth Jackson from the Perinatal Mental Health Hit. Perinatal is just everything to do with pregnancy and childbirth. The second one is Sani Norweg talking about the Eating Disorders Health Integration Team. And then the last one is the Suicide and Self-Harm Prevention Health Integration Team with Sandy Walker. Okay, so if you could run those videos, please. Thank you.
Hello, my name is Ruth Jackson, and along with Jonathan Evans, I co-direct Improve, the Perinatal Mental Health Hit. I'm also the CEO of local charity, the Bluebell Care Trust, that provides grassroots services for people affected by perinatal mental health difficulties across our region. And I'm also a mother myself with a lived experience. I'm really pleased to share that over the next year, the Improve Hit will be focusing on one major project called Breaking Barriers, where we will begin to scope and map the barriers faced by people currently underserved by our perinatal mental health services across the region. We know that perinatal mental health services are still not equitable for all. We know there are barriers in place, and we hope that this project will start the process of improving this by working and co-producing with people in communities with lived experience of facing these barriers themselves. And also the newly created role of an inclusion and diversity link worker who will work amongst the voluntary sector and other agencies, and will work with people to engage with them and listen to their experiences, and to co-produce some more meaningful interventions that we hope will enable access and services to become much more equitable and accessible for all in the future. We're really pleased to have secured several grants to enable this work to happen. One for the initial research and mapping of the existing data around access to services, and the others for the roles of the inclusion and diversity worker, and for the NHS Charities Together funding to be used to start the development and delivery of some more meaningful interventions that will come, we hope, as a result of the scoping and the mapping and the co-production work.
Hello, my name is Sani Norweg and I'm one of the directors of the Eating Disorder Health Integration Team. As you will know, eating disorders have been named as one of the key areas for transformation as part of the community mental health framework. This year we've had a really amazing opportunity to interlink our work as the ADHIT with the work of the community mental health framework for eating disorders. I've been named as one of the chairs of the steering group for the community mental health framework for eating disorders, and some of the other members of the ADHIT are sitting on the steering group, namely Helen Malson, who's our academic director, Katie Wild, who's our PPI director, and Caroline Trippick, who's one of our other PPI leads. So we've had a really good opportunity to impact on the developments of the model for the community mental health framework from various perspectives. We've also had an opportunity, as we've been allocated some RCF funding as the Eating Disorder Health Integration Team, to work on a primary care project.
Hello,
my name is Namurach, identification of eating disorders. This is also a focus of the Community Mental Health Framework Steering Group. So we're currently in the process of really trying to work out how that can be interlinked, so that we can really help the Community Mental Health Framework from a sort of research perspective on this particular issue. We also, as the ADHIT, have a very strong focus on prevention and early intervention. And again, those are two key main areas for the Community Mental Health Framework Steering Group for Eating Disorders. The preventative work will be partly delivered by VCSE, and our ideas around supporting them in their development, because there is no existing VCSE in BNSSG for eating disorders, are just developing. And the other area for development is around early intervention. That's a really clear model, and we will be supporting the Community Mental Health Framework around that as well. Many thanks. Bye-bye.
Hello, my name's Sandy. I am one of the directors of the Stitch HIT, which is a health improvement team aimed at improving the lot for patients who come through our services with self-harm or suicidal ideation. And I'm just going to quickly spend a minute or so talking to you about the most recent intervention that we've been involved in, which was creating some resources to go onto Remedy for the GPs to use in the area, Bristol and surrounding area, for people with those issues. So I'll share the screen quickly and show you these pages. So this is one page. This is the self-harm page, and on that page, as you can see, I won't scroll down the whole page, but you can see that we've got an overview here for GPs. The idea was that it was sort of 10 top tips, you know, really quick stuff that's easy to access and has a lot of information and links to things that are needed. So an overview of self-harm, questions that you might ask, some suggestions there, red flags, things to look out for, some resources for self-management, a link to our local service user-led service self-injury support, medically something about medically unexplained symptoms. There's lots of people with trauma come through with symptoms that look like physiological illnesses but are often unexplained and don't have the same results as those who have got those conditions. And then various resources. There's also a page here for those with suicidal thoughts, which we advise to read in conjunction with the page on self-harm. So whilst the two things are not necessarily linked, some people can self-harm without feeling suicidal. The fact is that self-harm is one of the best indicators of completed suicide, so we still tend to put them together on resources like this. So on here we also have the red flags again, but safety planning, resources for safety planning, some information about patients at crisis points, pointing towards counselling services, something called the Hope Project, which is an excellent project available in the community, and other sources of help. To finish, I'll just finish with this here. So we have some input from the service user perspective. We really wanted to have the service user voice as part of this, and we've involved people in the development of this page so that they've had a say in what it looks like. But I wanted to read to you a poem from a person who has self-harmed. Just stop sharing screen. From this book, you can see it. I don't know if you can see it. Oh, it's back to front, isn't it? It's called Who Am I by Emma Jane Stedden. And I thought I'd finish by reading you one of these poems. It's just one of the two poems that's on Remedy for GPs to look at. We wanted them on there because whilst it's important to have all this information, it's also really important to give them something that helps to get in touch with the actual experience and what it's like for people who self-harm. There's a kind of human element that isn't quite so easy to get across in bullet point lists, and so on. So this is called One Little Moment. A moment of sharpness, hatred, and pain is an hour of joy, 30 minutes of lust, 20 minutes of relief, 10 minutes of relaxation, 5 minutes of worry, 2 minutes of guilt, and a lifetime of scars. I want to scream, I want to shout, I want to let this misery out. I want to cry, I want to feel, but most of all, I want to heal. Thank you.
I noticed that the last part of that video really brings the experience of people into focus, doesn't it? And we were aware, the four of us, that it needed a moment just to sort of recognise that. And I suppose it reminded me there that involvement is also hard for people who've had difficult experiences, and that we as colleagues need to bear that in mind and make sure that people have got the right support. I think actually the Stitch Hit is a good example of a health integration team that's done a lot of work on this and has involved and supported people. But that I wondered what your reflections on those videos are.
Mm.
Certainly the video, the last video where the poem ended with I want to heal, from a service user, you know, that is all we want, is to heal. So yeah, it definitely hits the point for me anyway.
Yeah.
And also I thought it was really interesting that they in the first video they were talking about the mapping resources, and obviously we've done work on mapping resources, so you know, service user led involvement I think is a key part as well of a HIT. So yeah.
So getting the existing resources, and then the last video was producing resources. Actually, I didn't know about those pages, and I looked them up. They're very good. So that's developing resources for GPs with involvement as part of that process. Any other comments on the themes or what you took from those?
Can I go? I found the first and second videos quite impactful. We hear about mental health, we hear about self-harming, we hear about mental health issues around pregnancy, perinatal, and it's one thing to hear about it from a perspective that's maybe a newspaper or it's somewhere out there, you're having a conversation. But it's to hear about it from someone who's got lived experience is absolutely, totally different. and the impact of that. And for me, that poem, you know, I have never had such an insight into someone who's self-harming. That is someone describing why they do it, how they do it, and how it makes them feel. And the actual impact of that and the feeling that permeates that poem, it's a few lines, but it is massive. It's absolutely huge to hear that. And it makes you think of that human being and what could be going on in their world, why they would do that. We know what they're talking about, but it's almost as if the descriptive act doesn't feature into the poem. It's the emotional side of things. And that's very, very deep. And that's really important. And I think that's, you know, you go in public transport and you see things, because we don't like to talk about mental health issues. It still is very taboo in some places. Those are the poems we need to see on the trains or the buses, and have a read of it and have a think about, what could someone sitting in a couple of seats away from you be going through? Could they be somebody like that? And it would force us to be a lot more kind to others.
Yeah, it's a wider impact, isn't it?
Yes.
Carolyn, did you have any comments?
Putting me on the spot there. Yeah, I'd reflect on the poem as well in terms of that insight and that feeling. You can't get that from a textbook or from an academic. Like, it really is that lived experience that gives you that different perspective. So in terms of like PPI work, dealing with people with lived experience personally as well as carers as well, just gives that real like depth of insight around all these different mental health and physical health conditions.
It's a good point about carers as well, and there's a question from Ronald in the chat actually about in the Q&A section about the focus being on individuals, but also remembering the families and what measures there are around. I don't know whether we can answer that question on behalf of the Stitch Hit, but Ronald will certainly convey that question to them. I thought those films really exemplified the values of the health integration teams, and that the first one has got to be, you've got to ask the people who've been through it. That's where you've got to start. And that 10 years ago, that was one of the sort of central ideas of the Bristol Health Partners health integration teams. But also, you know, intervening early, prevention is better than cure. And then the other one, which I think has got more traction recently, which is about working out who you've left out. We've talked about that a lot today, haven't we, in the conference? Work out who you've left out and find a way to get them in.
For me, the early intervention stuff is exactly right. I knew nothing about recovery, and I thought rehabilitation was for rich people going, you know, paying to go to these fancy rehabs. And it was only a police intervention that I found out about recovery and treatment and stuff. And had I had early intervention, I wouldn't have spent 10 plus years doing what I was doing, because I knew nothing about recovery and treatment and stuff. So for me, had I have had any contact and any form of early intervention, then it could have possibly saved me years of being out. So yeah, early intervention is definitely also key. That came out as the videos.
I'd like to echo that. When I had an accident and I had to give up everything, job, you name it, I lost it. And I sat in denial for a long time, because a lot of things came into play. I wouldn't accept that my life had changed physically, which meant it had changed financially. It had changed in every possible way. And I lived every single day kind of hating others because they were getting on with their life. I wanted my life back and it wasn't happening. And I wouldn't agree with anyone that I was actually spiraling into a very deep mental abyss. And it took a very caring doctor to say to me, how about we think about this? just think about it. I'm not telling you to do it, just think about it. And I remember coming away thinking, she's right. You're just walking around with all of this and you're doing absolutely nothing about it. And I slowly but surely embraced what she was saying. And you've got to embrace things, what you said there, Darren, you've got to embrace it first before you can do anything else. And when I did that, I realized that, you know, I don't have to be in this lonely place where I put on an act for my family and my friends, and they ask me, are you okay? Yeah, I'm fine, I'm good, and I'm happy. When inside, I was hurting and I was hating, quite literally. And, you know, I think about where I was and I think about where I am now, and how great that the whole idea of somebody telling me you've got to think differently. Thinking differently is big. It's really, really big, because you don't want to think differently, because that's change. No one likes change. So it's good. It's powerful stuff.
Yeah, thank you, Primrose, for sharing that. There is a question for you in the chat, but I will come back to that. There's a comment up which is talking about involvement not being easy. This is from Eva. So especially when you've been through difficult experiences, you know, using those experiences to help others, it's really essential that the person feels supported at every stage in recovery. Sometimes a person may present in a certain way and people might either assume that they aren't well enough to be involved, or that they're not being affected by the involvement because they may present as sort of being well. It's essential in involvement that people are supported well. So I just wondered what you all thought about that sort of support, and have you guys received that kind of support as part of your involvement?
For me, definitely being part of the HIT team, being part of the PPI with ARC West, the support I've had to be involved and to get involved because I wanted to give something back, which is why I got involved. But having the support there, knowing that my voice would be heard and that I had a key role to play with lived experience, the support I've had to help me develop within HIT and within the PPI to have a voice and not be afraid to say something because I think it might not be listened to or it's not good enough. The support from everybody has enabled me to do this and be able to give something back, whether that is, you know, prep for meetings or being told what the agendas are and who's going to be doing what part and what's expected of me. But certainly the support I've had to enable me to be part of HIT and the PPI stuff with ARC West has been key for me to continue doing what I'm doing.
Has that been true for you as well, Carolyn? Thank you, Darren.
I definitely agree with the statement that was made in terms of like service user involvement. So I think the crucial thing is you want current involvement. So you want people to be currently like just still in services or recently left services to get current insight. And so therefore, you know, people might have difficulties or like need certain adaptations in order to do involvement, whilst at the same time being aware that actually people's mental health and physical health does fluctuate at times. So I know with some of the stuff that I've done, I've dipped in and out at different stages when I've been more well or less well. Yeah, I've had like supervision, things like pre-meets and debriefs and stuff like that, which has all been really helpful. But yeah, there's definitely a place for supporting service users and carers to being involved.
Thanks, Carolyn. Primrose, I think I'm coming to you for our sort of wrap up highlights. I have put a note in the chat, but I've also had a little note reminding me that we're coming to the end in the last minute or two.
So I'll be quick. I think the videos and what my colleagues have said are really, really important stuff. Involvement is really good for patients, and it's even better when you are looked after by the teams that you're involved in. Thank you.
Any particular highlights from you guys, David? Darren, sorry.
I think, yeah, the poem in the video is really hard. It came across really well, and just having service user involvement is crucial. Yeah.
Carolyn?
Again, I'd comment at the poem and just how powerful those few words can be to help people have a greater understanding.
Thank you. I would say that I've really enjoyed planning this with you guys, and also for everybody to remember that there are some emotionally difficult parts of this work, but there are also some real positives, and we had some fun putting this together, didn't we? So thank you very much, all of you, and thank you to the audience.
Thank you, everyone, to Joe, to Darren, to Primrose, and to Carolyn. It's been wonderful, and like has been said already, I found the videos powerful, emotional, and particularly the poem I found really quite emotional as well, and moving. I'm afraid we're going to have to draw this section to a close because we need to move on now. So if we could have the slide back up, please. And we're now going to move on to children and adversity and trauma in our region. So the next section, again, which is for 20 minutes, is going to be co-led by Anne and by Joe, and therefore I'm very pleased that they've been able to join us. And Anne, over to you.
Hi everybody, it's really lovely to be with you this afternoon and to be able to talk about the adversity and trauma hit and the progress that we've made over the last year. I'm going to, as David has said, I'm going to do this with Joe, who is going to insert the right academic rigour and the research information at a suitable point. But I also need to really recognise John McLeod and his massive input into the adversity and trauma hit as a co-chair of that group. Next slide, please. And next slide, please. Okay, so just to kind of orientate ourselves, the overarching aim of the adversity and trauma hit, which was established in 2019, is to develop and use research intelligence on adversity and trauma to inform service design, which will then improve outcomes for residents across the life course and reduce health inequalities. So it's a multi-agency hit spanning Bristol, North Somerset and South Gloucestershire, and is a steering group that works with other forums and partnerships to embed trauma-aware and trauma-informed practice right across the system, and taking a real life course approach and developing that real learning loop about where we're able to have the greatest impact. So you can see the examples there. There's been a trauma subgroup of the mental health cell that's been operating, working with across safeguarding partnerships into education, our health and wellbeing boards, which have adopted the trauma-informed principles this year, which is fantastic news, and the Healthier Together, the integrated children's care system as it develops. Just to note, there's a kind of shift really. We were called the Adverse Childhood Experiences Hit. We're now called the Adversity and Trauma Hit. It is one and the same, and maintains a life course approach. It really represents that move away from understanding adversity in terms of a kind of list of adverse conditions or adversity that you face in life, to recognise that it's very much a range of adversity. It is determined by context, prevalence, type. It can be differentiated. So, for example, physical or sexual abuse might have a different impact on you than parental divorce. But also that, you know, it's not an exhaustive list, and we experience what we experience in the way we experience it. So, you know, the pandemic and the impact of COVID, you know, being a real live issue for us now, but also, you know, understanding those kind of other factors, environmental factors, racism, poverty, and so on. So we've moved to the language of adversity and trauma. We both referring to the experiences of chronic stress in life. So next slide, please. So this just reminds us really of some of those trauma, some of the types of trauma, and locates us in this work. So the research on adversity makes a really compelling case for our work, and for continuing to develop our understanding of what works in reducing adversity and supporting recovery. These specific figures that you can see here come from the Welsh ACEs study that Bellis and colleagues undertook in 2015, but it really echoes findings elsewhere across England, Scotland, and across Europe as a whole. So you can see that adverse childhood experiences, stressful experiences occurring during childhood that directly harm a child or affect the environment within which they live, and aren't, as I say, the only things that cause trauma. You know, there are a host of other types of adversity that people face and experience. And we know that there's a graded relationship between the number of adverse childhood experiences reported and childhood outcomes. We also know that adversities co-occur. So children who've experienced one form of adversity or trauma, much more likely to report another and are predisposed to experience further forms of trauma, and for that to have an amplified impact in life. So just a note of hope in this. There is absolutely nothing inevitable about trauma and its impact. We can operate in a way that reduces trauma, that reduces the severity of impact of trauma, and that supports people to recover. Our brains that are managing our responses to trauma are amazing things. So they can shape and adapt, so that neuroplasticity, that ability to recover, is there for us if we create the right conditions to do so. So next slide, please. So we really need to think in terms of people in our communities and the other factors in their lives. And this diagram is really, you might be familiar with it, but it's a really great diagram, isn't it, about the tree and the roots. And so it shows that ACEs aren't limited just to the individual, but also linked to the environment. And it's a critical interrelationship, isn't it? So I'll give you a brief example of that. I was listening to feedback from parents about a newly established small team in Bristol that is really working with parents and professionals, actually, of children with disabilities and special educational needs. And it's about making that the local offer come to life. And it's a very proactive team that is helping to build that network, because of course, having a disabled child is not in itself the trauma. The way that the system operates around and enables or disables you in terms of you living your life and your child growing up and developing, that is the trauma. And so to listen to that team being able to work in between the roots of the tree and some of the the individualized adversity that might also be around in that family or in that child situation was really fantastic. And to hear about a very small team who are really, you know, following up on families and in front of that and helping people to recover and to navigate the landscape was really truly trauma-informed practice. Next slide, please. So this just takes us from that definition of trauma, moves us towards thinking about trauma-informed practice. So very deliberately, our thinking and our response in the trauma and adversity hit is not just about targeted or specialist services and our response to it. It is about culture and about system change. So it's absolutely about the way we think and the way we do things around here. Trauma-informed practice, of course, informed by neuroscience, psychology, social science, as well as attachment and trauma theories. It gives a central role to the complex and pervasive impact of trauma on a person's worldview and relationships. And it's applicable across all sectors and system-wide. So not solely in the world of health and health delivery, or children's services and children's delivery, or adults, but absolutely, you know, we can think about being trauma-informed in terms of our interactions with getting onto buses, or with people who are collecting our refuse, for example. It really is about making every contact count, as well as thinking about those small changes that we can make in our environment so that people feel psychologically safe and welcomed when they're facing perhaps a situation that they might find threatening. So next slide, please. So what does that mean in terms of the way in which we are responding? Well, we're working with partners to develop a whole system and life course approach that really thinks through how we take that whole system: prevention, recognition, and then support around recovery and building of resilience. On the ground, the HIT is working with and supporting a number of both projects, organisations and agencies that are really adapting and rethinking the way in which they not just deliver services. I want to say deliver services, and that's because I come from a service delivery background. But it's so much more than that. It's about the way we interact. It's about our interpersonal relationships and the way in which we build connection with people. And we have, I think the adversity and trauma hit has absolutely captured the zeitgeist. So there has been an absolute organic growth in that thinking, as well as a system-wide thinking about how we improve our responses as service deliverers. So if we go to the next slide, please. This just helps us do that systems thinking. These are the implementation domains that we are thinking through in terms of taking forward a trauma-informed approach and developing trauma-informed practice. It's developed by the Scottish Government, actually, and we have nicked it because it's really good and a really helpful framework. And it builds on other learning and literature and models of trauma-informed practice and organisational change literature. So being applied across a variety of agencies, including actually into Avon and Somerset Police Force, whose violence reduction unit has secured some funding to begin to develop into a trauma-informed organisation in the police, which is just fantastic. Similarly, our ICS has put trauma-informed practice at its heart and is one of its design principles for the new system. So those are some really key game changers, I think, in agencies across the city. If we go to the next slide, please, thank you. You can see some other examples of good local progress, but I'm going to ask Jo now to talk, because she's going to give you some of the developing evaluation and research in our local area that's underpinning some of these examples of good practice and our ability to evaluate them.
Thank you, Anne. Yes, just wanted to flesh out a little bit more about what we've done on evaluation and research in the HIT. The HIT is a great platform for engaging with our local universities and research infrastructure. It enables us to then build this work on an evidence-based platform, but also together with our academic colleagues to contribute as well to the evidence base. So I'll just mention one or two particular areas we've developed that we've really valued. Anne's already introduced John McLeod. We're very fortunate that he's both the director of this HIT, but also of our local applied research collaboration. And together there's some very interesting research developing, for instance, looking at the economic case for trauma-informed services and this trauma approach. So we're grateful for colleagues who are here today who are contributing to that work.
That is really powerful, isn't it, I think? And I think she doesn't say it in that point in the clip you've seen, but Rachel says there's a part where she says she realizes that it wasn't her fault, and that, you know, where she's talking about throwing off the covers and being herself, that gave her the opportunity to open up and introduce the possibility of change for her, and that is, you know, that is the hope, isn't it, and the opportunity that I hope that we can give to all of our communities and people right across the life course, because adversity and trauma happens, but we can work together to create change. So the slide that was just there was a kind of call to action, really, that incorporates that. Those are our adversity and trauma informed principles that have been adopted across the BNSSG area. They are based on some work that was previously done by Substance Abuse and Mental Health Services Administration, but includes inclusivity as a sixth principle, because that's what people, we talked about it, consulted upon it, and that's what people wanted to see referenced, and I think makes it a really, you know, really strong set of principles. So I guess my ask is, think about that, think about how you take that away into your life, into your organisations, and how together we continue to develop a trauma-informed system.
And thank you very much indeed. We're, I'm afraid, a little short of time, so we're not going to be able to take questions now, but I would request that if people put either into the chat or QA any specific questions, we can then pass them on to Jo and Anne and deal with them offline, because these are really important issues. I'd like to thank both Anne and Jo. Could we take the slides down, please? That's been an excellent session, and I really wanted to emphasize the point that Anne made, that these are not fixed outcomes. However bad life seems, you can always turn things around. And indeed, I often hear many people say, well, it's very time consuming, it's very labor expensive, it's extremely expensive to do this with one-to-one care. But the outcomes for those individuals and for that family dynamic are absolutely massive. There is so much literature that show, however bad things are, you can move people back up the road, back up the scale, and their outcomes get so much better at the end of it. And that is probably about the most cost-effective thing you can do over the lifetime of that individual or that family. So I don't want to labor the point more further, but you know, if we as a community do nothing else in the BNSSG area, adverse childhood experience is probably one of the most important things we can and should and are focusing on. So I'm afraid we've come to the end. We are almost at the end of our conference, so I would like to thank again both Jo and Anne for leading that session, and indeed all of the other contributors, and particularly our public contributors. I think this has been a wonderful 2-hour session. I hope it's given you really good insight into the breadth and the depth of the work that we are doing across all of our 20+ health integration teams. It's also been, I think, really demonstrates the power of the collective system-wide approach and how we can really alter and address what are often called wicked or very knotty problems that tend to be put into the far too difficult box. We'll come back to that, and indeed as a result one almost never comes back to it. So the ability to address problems like this at scale across the entire system, I think that, I hope, is one of the things that the integrated care system and Bristol Health Partners can really do together. And that is why we're so delighted to have our new research and innovation steering group that is going to act on behalf of the entire system. So I'd like to thank everyone for their contribution. I'd like to thank all of you for attending. And I'd particularly like to thank, first of all, Autumn Live for their technical support, and particularly the core Bristol Health Partners team, Louise Osborne, who really did a huge amount of the work setting the conference up, the team, and particularly Ollie and Lisa. And lastly, although Lisa has specifically said to me that she doesn't want me to say anything about it, I'm going to anyway. So you're going to have to live with that, Lisa. Lisa, this is her last conference. She very sadly is going to be leaving Bristol Health Partners. She has been a massive contributor and leader to everything that we've done. And I, for one, would like to thank her and all the work she's done. So, without further ado, I will draw the conference to a close. So to thank everyone, and I hope you all stay safe and well. Bye-bye.